That's great. That makes me feel better because I had no idea where that was. Um, okay, so what are you going to do if this person comes into your OB office in your practice? Is one of the first questions I wanted to sort of cover. And then I want to talk about treatment, particularly medications for opioid use disorder, and why it's so important we get everyone up to speed with prescribing. So to answer the first question, if you had this patient come into your office, you could literally pick up the phone and call us. This is our number down here, 843-792-MOMS or 6667. You could scan this QR code. And what would happen is that you would talk to our care coordinator, who's going to get some information from you, learn a little bit about the patient so we can follow up with the patient, but then put you in touch with one of our reproductive psychiatrists that can talk with you about the case and sort of next best steps. And then we can help follow up and coordinate care for that patient, just to make sure that they get connected to care and that they're doing well. So any sort of healthcare provider, that's a doula, a midwife, obstetrician, pediatrician, psychiatrist, et cetera, can call this number and get sort of next steps around how we're going to get this person connected and into care and back into treatment. And the reason why this is so important is that we all know that right now, the most frequent underlying cause of pregnancy-related death is actually mental health conditions. And it's not just mental health conditions, it's that a big driver of that is drug overdose. So drug overdose, particularly around opioids, is what's really one of the major drivers of maternal mortality in our country. And that makes sense because in the backdrop of this, in the general population, we have an opioid epidemic where we have increasingly more and more deaths every single year due to drug overdose, primarily driven by opioids. And that is just being mirrored in pregnancy. So the way that we address this, and again, this is just even more recent data, like this is not going away in pregnancy. The numbers of women that are in pregnancy or the postpartum year that are overdosing and dying continues to increase. And just to give you a sense of what's driving that, it's our mainly synthetic opioids, our fentanyl. And then also what is also the timing of that is mainly during the late postpartum year. So yes, it's important to get this person on this medication in pregnancy and postpartum, but it's really the postpartum year that we want them to continue this medication. Opioid use disorder, opioid overdose deaths is a good proxy for the amount of opioid use disorders that are out there. And in pregnancy, we just see these numbers continuing to climb. So when we're talking about treatment of perinatal opioid use disorders, we really want to think about mom and baby. For mom, we really want to make sure that we are addressing her needs, her mental health needs, and any history of trauma. We're doing that with psychotherapy and or medications, particularly medications for opioid use disorder. We're looking at all of her psychosocial risk factors and sort of lack of resources and making sure that she's getting connected to resources that are needed. We want to do this in combination with OB and mental health and psychiatry all in one place. And those sort of integrated treatment models are the best, but they're really hard to find. So we sort of are doing that in this virtual space. We try to integrate as much as possible via telehealth or by even just calling us to get treatment. I want to really focus on the medications for opioid use disorder because this is actually what is life-saving. So methadone or buprenorphine have been shown time and time again to reduce opioid use, related overdoses, mortality, criminal activity, transmission of infectious diseases, and also have been shown to increase social functioning, employment, and retention and treatment. So these are literally life-saving medications, and we know that many people are not on them that need them. So the same holds true in pregnant women. The recommendation is that if you have an opioid use disorder and you are a pregnant or postpartum person, you should be on a medication for opioid use disorder, whether that's buprenorphine or methadone. So there is really nice guidance put out by SAMHSA, Substance Abuse Mental Health Services Administration. If you wanted to know anything about the clinical management and treatment of perinatal opioid use disorders, this is a fantastic resource. Also because it's sort of organized in a really quick and easy fact sheets, like helps you figure out what do I need to do with this patient. And I'm just going to walk you through just the most critical elements of this.
Sorry, Connie, I accidentally muted you. Can you unmute?
Yes.
Sorry about that.
That's okay, no problem.
Okay.
Main thing is just that if you are pregnant or postpartum and you have an opioid use disorder, we want that person on methadone or buprenorphine. We do not recommend that people withdraw from those medications during pregnancy. That's not the standard of care or should be done. And we also do not want to transition from one of these medications to another. So if you're on methadone, we really don't want to transition you to buprenorphine, or if you're on buprenorphine, we don't want to transition you to methadone. We want you to stay on the medication that has worked the best for you. So if one of those medications isn't working, we consider a transition, but otherwise we just want you to stay on that medication. The dose of those medications are going to need to be increased over the course of pregnancy. And we're going to talk about that a little bit in a little more detail. But that just has to do with the normal physiological effects of pregnancy, lowering the levels of those medications as people take them over pregnancy. Breastfeeding is recommended for women on these medications, including those that have hepatitis C. So when we are talking to people about taking these medications in pregnancy, what you really want to do is you want to talk to them about what are the risks of these medications, but then we also want to talk about the risks of not being on these medications. So the risks of these medications, obviously, a lot of times people don't want to be on these medications. There's a preference not to take them during pregnancy, and sometimes they are difficult to access. The newborn and obstetric risks of these medications is that we do see an increased risk of prematurity, low birth weight, and neonatal abstinence syndrome or newborn opioid withdrawal syndrome, which can extend hospital stays and are costly and can be really difficult on women whose babies are in the NICU and going through withdrawal. But we can talk through more of that in just a second. What you're doing is you're sort of weighing those risks against that woman not being on these medications. And so the risk of not being on these medications is obviously relapse. And so when you are relapsing to a substance in pregnancy, you're often not taking that drug in a steady state. You're going through these cycles of intoxication and withdrawal, which are really bad for the milieu and the woman's health and the baby's health. Depending on how you're using these medications, we have risk for infections. We have a lot of high risk behaviors associated with drug use that put women in harm's way. And then obviously risk of overdose and death in the use of drugs. When people continue to use substances during pregnancy and they have an increased risk of prematurity, low birth weight, severe maternal complications, and neonatal abstinence syndrome or newborn opioid withdrawal. We also really worry when women are using in pregnancy that at the time of delivery that there might be an intervention that is going to separate mom and newborn, which is what we don't want to happen. So a lot of times people will say, okay, well, which drug, which should they be on, methadone or should they be on buprenorphine? And the short story is that you want them to be on the drug that is going to work the best for the mom. And you want to look at what the risks are associated with these medications. So this is the largest study to date, really comparing buprenorphine versus methadone for opioid use disorder in pregnancy, looking at these risks and outcomes, NAS, preterm birth, small for gestational age, low birth weight. And so you can see sort of the risk estimates here with buprenorphine having 50% of those kids going into having NAS versus methadone, which is a little bit higher, almost 70%. Preterm birth for buprenorphine is around 14%, methadone is around 24%. Small for gestational age, roughly this, similar percentages, but less in the buprenorphine group. And then low birth weight, about 8% buprenorphine, methadone is about 14%. And so what we sort of, this data is very helpful just to give women a sort of estimate of their risk of these outcomes. But what we don't want to happen is we don't want you to choose buprenorphine because it has this slightly more flavorful profile for the newborn. What you want to do is choose the medication that works the best for the mother. Because, and what that medication is that can she access it? Is it available to her? And is it going to reduce her risk of relapse? That is the best medication for mom. What you don't want to do is say, oh, well, buprenorphine looks a little bit better. I'm going to switch from methadone to buprenorphine because we don't actually know if that methadone is going to be better And we risk potentially destabilizing that mom. You can easily, if you go for methadone to buprenorphine, it's very easy to precipitate withdrawal. You now have exposure to 2 medications in pregnancy as opposed to 1. And if it's not effective, you have continued exposure of untreated substance use disorders and risk for relapse. And we also don't know if I switch from methadone to buprenorphine, is that actually going to lower the risk of NAS? We don't have any data to support that whatsoever. So take home message is use the medication, buprenorphine or methadone, that is going to work the best for the mom and keep her stable over the course of pregnancy and the postpartum year. Okay, so say you do have a mom, this mom came into you, this patient that we just went through, and it sort of makes sense to get her started on Suboxone. And pretty soon, all providers are going to be able to prescribe buprenorphine with a little additional training, but you don't need to actually go get a license for this or go through the full day training to be able to prescribe this. But as a practitioner, you can, this is now a medication that is going to be available to you very soon. And the way that you want to dose buprenorphine in pregnancy and postpartum is the same way that you would in another adult. And you start with what we call an induction. So the induction, we'd say this is day 1, not a pregnancy induction, a buprenorphine induction. But on day 1, what you want to do is you want this woman to go into withdrawal. And you're going to use a clinical opioid withdrawal scale. And you can do this in your practice. You can also educate people and send them home to do this at home when they go into withdrawal at home and a little bit more comfortable doing that at home. So you want a clinical opioid withdrawal scale of at least 8, if not a little bit higher, particularly if somebody's using fentanyl. Once they get into that withdrawal state, then they can take 2 to 4 milligrams of buprenorphine. I typically start with 4 milligrams, and they're going to wait 30 minutes. They're going to see, did they respond to that? Did they tolerate it okay? And if they tolerated it okay, then they're going to take another 4 milligrams of that drug. That's day 1. Day 2, they're going to go up by another 8 milligrams, and they're going to take a total dose of 16 milligrams that day. So 8 in the morning, 8 at night. Eventually, you can switch them to once a day, but this is sort of day 2. They're going to start at this dose, the stabilized dose of 16 milligrams total. Going forward, you are only going to adjust that dose in response to craving, withdrawal symptoms, like not fully effective yet. Then you might increase the dose. And I'm going to talk about in a second about how you do that and when you do that as it pertains to pregnancy. So when you're going across pregnancy, as I mentioned before, there are these physiological changes that are going to result in a lower level of buprenorphine in that person's blood. And when you get to that lower level, cravings are going to come back, withdrawal symptoms are going to come back. And so you want to tell the woman from the get-go, hey, over the course of pregnancy, we are going to have to increase this drug. And I'll just tell you a quick anecdote because I think it helps for people to sort of remember. We've actually had a patient end up in the emergency room because she finally got started on Suboxone. It was a miracle drug for her. Her addiction got back under control. She was pregnant. She was doing great. And then the drug just stopped working. And she really just thought it stopped working and didn't realize that she just needed a higher dose of the medication. Of course, she wouldn't know that. But we really need to give people a heads up that like, you are absolutely going to need a dose increase of this medication over the course of pregnancy. A lot of people will push back on that because they think that going up on the dose of the medication is going to increase their newborn's risk of withdrawal or NAS. And that is not true. So there's lots of data that basically demonstrates that that's not the case. There are so many other variables that impact that outcome, and it's not dose of buprenorphine or methadone. So first thing that you can do is you can say, okay, I get maybe you don't want to go up right now. You're going to eventually need to go up. But one thing we can do is split your total dose. Sometimes taking that dose twice a day, 3 times a day, even 4 times a day can help to sort of prevent some of the withdrawal symptoms or cravings that can pop up. But otherwise, if you're still having withdrawal symptoms and cravings, then we're going to increase the dose of the drug because it is not helpful to have a drug on board that's subtherapeutic. You're taking all the risks of the drugs and then also the risk of relapse all at the same time. So you want to go up on the dose, get it therapeutic so that people are not relapsing. You're going to maintain that dose throughout delivery. Do not make any adjustments for pain management around delivery, labor and delivery, C-section, everything. Do not change the dose of buprenorphine or methadone. Keep it the same. Postpartum, if you went up a lot on the methadone or buprenorphine in pregnancy, you're going to need to come back down in the postpartum period. Like within that month postpartum, you're going to make some adjustments so that person's not overly sedated and they're on sort of the optimal dose of that medication. And this is something that, again, you can call me and I'm happy to walk you through all of these steps and do a buprenorphine induction in your clinic anytime, Monday through Friday. We don't have enough personnel to do weekends yet, but we are really here to support providers in doing this work. And I'm going to stop there.